Hello, everyone, and welcome. Thank you so much for attending today's webinar, which is brought to you by ISCOS Quality of Life Special Interest Group. I am Dr. Angela Hanks, co-chair of the Quality of Life SIG, and I'm a psychosocial outcomes researcher in the Department of Rehab Medicine at the University of Minnesota Medical School in the US. And I am pleased to introduce our speakers today. We have Doctors Sarah Ahmad and Rania Solomon, and they will be presenting on the SCI QOL patient-reported outcome measures in spinal cord injury rehab, implementation results, and lessons learned. So Dr. Ahmed is a professor in the Faculty of Medicine and Health Sciences at McGill University in Canada and a clinical epidemiology researcher affiliated with the Research Institute of the McGill University Health Center and the Center for Interdisciplinary Research and Rehab. She is the scientific director of the Quebec Digital Health Network and co-directs the McGill Center for Health Measurement. She also leads the Brilliant Learning Health community. Her work centers on designing, implementing, and scaling digital health solutions, as well as integrating health outcomes, including patient-reported outcome and experience measures into routine care and to support better decision-making for people living with chronic conditions. And then we also have Dr. Rania Solomon, who is a research coordinator based at Brilliant Lab at McGill University in Canada and an active member of the Brilliant Lab. Her work focuses on the integration of patient-reported outcomes and chronic disease care through the development of implementation digital health platforms. She manages multi-site implementation and evaluation studies across Canadian rehab centers, including projects in spinal cord injury, chronic pain, and pulmonary rehab, with a strong emphasis on real-world clinical integration, ethics, and data governance. Thank you both for being here, and we are so excited to hear your talk, so I will hand it over to you now.
Thank you very much, Angela, for that very comprehensive introduction. Thank you. So we're happy to share with you some of the work that we've been doing. As Angela mentioned, our team is working on integrating patient-reported outcomes into different projects that we're working on with clinical care teams and rehabilitation sites. I'd just like to start at the next slide to acknowledge the rest of our team. I think, Rania, if you can go to the next slide, who was involved with us in this spinal cord injury project. It's a multi-site project across different provinces in Canada, and I'll share with you a little bit more information about those sites. So what we're sharing with you specifically today is to talk a little bit about PROMs, just to make sure we're starting sort of on the same understanding of what our patient-reported outcome measures. Describe the SCI QOL measurement system, which is we collaborated with Dr. David Tulsky and his team to culturally adapt and translate them to French to be able to better use them here in Quebec, where both our official languages are English and French. Review with you some of what we learned around the implementation challenges and how context matters in thinking about rolling out an EPROM platform. And then share with you also some of what we learned around strategies that help facilitate use of PROMs integrated within clinical workflows. This is a definition of a PROM, and many of you are likely familiar with this. If this is the Quality of Life SIG, you've probably discussed patient-reported outcomes extensively. But just to remind everyone that when we talk about PROMs, what we're really referring to are measures or a report that can only be reported on by the individual themselves without interpretation of the patient's response by anyone else, a clinician or a family member. So we're really talking about things that are objective measurements from the individual's perspective about how their health is impacted by their condition. Patient-reported outcomes play a really important role in spinal cord injury, and hence why the suite of measures in the SCI QOL were developed, not only in terms of the important impact of the number of people who live with the effects of a spinal cord injury, but also the resulting functional and participation limitations, and just sharing with you some numbers of what's been reported in terms of impact on sexual dysfunction, bladder, as many of you know, and often individuals are managing multiple impacts of having a spinal cord injury. We know from previous work that the use of patient-reported outcomes helps to improve communication and make sure that needs that might go unnoticed are more directly addressed through care. But also it captures areas that patients and families have reported are important to them, aspects of quality of life. And so having patient-reported outcomes completes that puzzle of evaluation to address areas and ensure that, especially as individuals transition from hospital to rehabilitation back into the community, that needs can continue to be addressed. So integrating patient-reported outcomes, there is support from the literature that it does help improve communication, detect concerns, and help support patient engagement. So we've seen links between measuring in a standardized way outcomes that matter to patients and their engagement within setting goals and following along with their care with different rehabilitation teams. Systematic reviews have also shown that integrating PROs helps to support decision making and shared decision making between clinical teams and patients. So it provides, like I said, a piece of the puzzle that complements what already clinicians evaluate within rehabilitation care. Within spinal cord injuries specifically, there's been extensive work that's been done around thinking about what outcomes are important to evaluate. The SCI QOL specifically has been developed as a computerized adaptive test, which helps to reduce burden. I'll say a few words more about that shortly. And from the work that's previously been done, there's been some studies that have looked at integrating PROMs in rehabilitation in general. And some of these studies have included subgroups of individuals with spinal cord injury. The extent of looking at how these measures were integrated is a bit varies between the studies. Essentially, the majority of them looked at system level barriers. What we were really interested in with this work is really thinking about which outcomes and prioritizing them in terms of asking individuals with lived experience and others to prioritize a certain set of outcomes. We'd like to measure everything, but we know that within clinical care, the response burden is really an important factor. And we ask the question, what is a core set that we would want to evaluate that would be important to assess for every individual with a spinal cord injury that could be integrated within care and provide real-time feedback to the clinical team and to individuals themselves. And we'll talk a little bit about that challenge around that feedback loop and share a few thoughts about what can help strengthen that feedback loop. The ideal situation would be that patient-reported outcomes would be regularly collected. So starting at number one here, that the team would have a chance to review the scores before seeing the client, that the scores would then be discussed within clinical counters to support shared decision making, and that scores would be considered in developing a personalized care plan with patients and families. But also at an aggregate level, that those patient-reported outcome scores can also be used for continuous monitoring to track progress and make adjustments to services that are offered to individuals with spinal cord injury, not just within rehabilitation, but when individuals return back into the community. And that improvements can continue to be made in adjustments at an individual level, but also at a program service level. So specifically in our work, what we aim to do, and this work is supported by the Craig Nielsen Foundation, is to develop a core set of spinal cord injury domains that would be collected regularly throughout clinical care. And we put together a stakeholder engagement team that included patient partner representatives, clinicians, and as well as managers and decision makers at a system level, to then implement the system and evaluate the feasibility, acceptability of using the EPROM system, assess its impact on patient-centered care, which we saw as sort of an early on impact of using patient-reported outcomes, and then to ask about the barriers and facilitators. One of the great advantages that we had in this study is the collaboration across different provinces. So care in Canada is at a provincial level. So the context does vary, but also the types of centers are slightly different. Even though they're recognized accredited programs in spinal cord injury care, there are some differences between the sites. And so implementing in those different contexts helps us understand implementation a little bit more by looking at the differences in the context, and I'll discuss that a bit further. So in the co-design of the e-platform, we engaged each of the clinical teams. We then developed and iteratively adapted the platform, and we used REDCap as sort of the base for creating the platform that's now called AboutMe. And then we implemented it in each site to a different extent. So if we look at the implementation timeline, this study got funded way before COVID, and we had a lot of starts and stops in the project. So we actually started the study in 2019, conducted a Delphi evaluation, and then started co-creating the system in 2021, and then finally launched in 24 and was able to evaluate outcomes and impact on patient-centered care in 25. So it gives you a sense that the people involved changed over time just because of the context, and the level of participation also changed just because sites were having to deal with other commitments and priorities at the time. For those of you who are not familiar with the battery of measures in the SCI QOL, there are different domains that evaluate physical, emotional, social participation, and stigma and self-perception. Our goal in the first phase was to say, amongst these subdomains, what are the top domains that should be assessed in every clinical encounter? So we collected we targeted and sampled across health professionals, individuals with lived experience, and caregivers across Canada. We conducted a Delphi process to prioritize the top domains that we would want to include. We went through 3 rounds, and then we identified the most important patient-reported outcomes as identified by individuals with lived experience, caregivers, and health professionals to come up with a minimal core set. The minimal, what we found in each round, and we used 70% consensus to keep a domain. So we did the first round. In the first round, what did not reach consensus is what you see in the first column. What did reach more than 70% consensus in round 1 is in the second column. And then what we did in the second round is we brought forward the domains and shared with participants what did reach consensus and what didn't, and asked people again if they agree with the decisions that were made in terms of what to include in the core set. What you see in green is what some of the clinical partner sites asked us to push in. So even if it didn't reach consensus for everyone, we still decided to push them forward because sites felt that they would need to evaluate that. And what you see in the orange are domains that at least one of the subgroups, mostly individuals with lived experience or caregivers, identified as more than 70%, even if the other subgroups didn't. And so we pushed those into the core set and asked for another final voting with a rationale of why we added a specific domain if it hadn't reached consensus. And what you see in the final column is the final core set that was kept within the platform. Just as a reminder, I mentioned that the SCI QOL is a computerized adaptive test. And what that means is that the items that are administered to an individual within a given domain is based on their responses. So there's an item that's evaluated sort of at the middle level of ability, like let's say wheelchair mobility, It's somewhere in the middle. If they do well on that item and it seems like it's easy for them to carry out a certain task or activity with their wheelchair, the next item is more difficult. And so it selects the next most informative item to come up with a final score, and based on the stopping rule, estimates that score. And what it buys us is efficiency. So instead of having to ask all the items in a given domain, it targets a person's ability from the beginning and chooses the items that are most relevant for them, to come up with a score. It helps to evaluate a large number of items while saving us time and having the same level of precision so we don't lose that level of precision for a given score. So in the next slide, I mentioned that we have three provinces and that healthcare is provincial. So we initially collaborated with one group with one rehabilitation center, the RGLM in Quebec, in Ontario, GF Strong, and in Ontario Parkwood, and in Vancouver, GF Strong. And we had a lead in each, myself here in Quebec with Dr. Susan Bartlett, with Dr. Dalton Wolf in Ontario, and Dr. Ben Mortison in Vancouver. I mentioned context matters, and we know from the excellent work that's been done before by Dr. Dom Schroeder that when we're trying to implement a new practice, and we use different implementation strategies, the success and which implementation strategies we use will depend on context. It will influence the success and adoption of the outcomes, and ultimately impact further down the road longer term outcomes. So we wanted to take that context into account, and we did that through the evaluation in terms of looking at acceptability and feasibility. So what we saw right away is just in the exchanges with the clinical teams in each site, the way that they wanted to implement the EPROM system varied and in which programs they prioritized us starting with. So in JF Strong, we had a lot of exchanges of using it with the clinical team, and ultimately, because of different challenges around integrating it into the workflow, the decision was made to administer the SCI QOL after individuals, to individuals while they're in the programs, but not integrated into the clinical workflow. In Parkwood, it was the complete opposite. They were at the point of using an electronic medical record, and our IT team worked with their IT team to integrate or plug in the EPROM system within their EMR, and the clinical team was fully engaged. For the Montreal team, they were very heavily engaged in the beginning, but after COVID, found it challenging to integrate the EPROM system into their clinical workflow. And after that point, we worked with Memo Quebec to administer the EPROMs with their members, rather than it be integrated into any aspect of the clinical workflow. So we used an integrated knowledge translation approach with each three sites, and each landed in a different place. We are currently looking at the results with each of the sites and reflecting through what would come next as a next step for using the EPROM system. In the study in GF Strong and Parkwood, we used a mixed method study design to evaluate the feasibility and acceptability of using the EPROM system. We also were interested in looking at practice change. So in the next slide, and we used both, so mixed methods being both using questionnaires as well as qualitative interviews with patients and clinicians. So in Parkwood Institute in GF Strong, you'll see that we had data collection for a handful of patients. So in GF Strong 31, in Parkwood 11, we did qualitative interviews on both sites and did an integration of the results that we'll share with you today. Just to give you a sense, when we administer the SCI QOL, this is the type of feedback that clinical teams can look at. So, for example, here you see the subdomains: depression, pain behavior, pain interference, pressure ulcers. And the way that the SCI QOL is measured is the same as other patient-reported outcome measurement information system tools, PROMIS tools, is that it's based on the population general average, at a mean of 50 and a standard deviation of 10. So what that means is when it starts to enter the yellow above 50 into the red, it means that there are starting to be challenges below the population average, in red, much further below the population average. So in a snapshot, what you could see for each domain is where is a person in terms of their scoring for depression, for pain behavior, for pain interference. If they're in the yellow, you would want to start to have a discussion around that. If it's in the red, it would be more urgent. And if it's in the green, then it's not as much of an issue. So you could see right away that number one, it helps to capture the areas that might be challenging for a person, but also it helps to facilitate the communication about their goals and their care plan. So this is again to patients where you might see more variability now with a different set of subdomains: independence, resilience, self-efficacy. Same thing, you'd sort of see where do they fall relative to the average. And if there are any areas that are problematic, you could discuss those early on. The other areas, and Parkwood felt that this was important, they asked us to include more domains around social health and sexual health that they felt they wanted to include. And just as a by the way, even though we had the 10 core domains, the platform did allow a clinician, if she or he felt that it was important to ask about an additional domain, then they could pick additional domains within the SCI QOL. It's just that the system required them to complete the core set that were identified as priority domains in the Delphi. But this just gives you another sort of sense of how the dashboard or the feedback scores are used. And it helps to sort of be able to see other areas of life that are impacted by spinal cord injury and integrate those into the treatment plan. More at an aggregate level. So the next one, okay, we're not at an aggregate, but this is another example of an individual profile. It just gives you an idea, what's in red: basic mobility, ambulation, self-care, suggesting that these are priority areas to target. Resilience and self-efficacy seem to be doing well. And then some things in the middle were pain interference, pain behavior. So it gives you the context. If you could know more about the individual, look at the combination of the scores. It helps to represent a little bit more realistically the complexity of the lived experience of individuals with spinal cord injury, and to be able to plan a comprehensive treatment plan. And you can imagine the value of this over time. So things might change from rehabilitation back into the community. We've seen this through focus groups we've done where individuals experience different challenges once they're back home. And so being able to monitor PROMs helps to flag that relatively early and help with service planning as well. One of the outcomes that I mentioned that we looked at is acceptability of the EPROM platform, and we use the acceptability E-scale. So it gives you a sense that in terms of the patient perspective, it's pretty high in terms of their rating of understanding, ease of use, time burden, acceptability. And it also reflects that we co-designed this with patient partners. So it was good to see that overall acceptability was relatively high. The other question we asked is, how will clinicians integrate this into their clinical workflow? And because it was only Parkwood that integrated this within the clinical workflow, we only had a handful of clinicians. So do take these scores with a grain of salt. So the normalization measure development evaluates integration to clinical practice through 4 constructs: coherence, cognitive participation, collective action, and reflexive monitoring. And a higher score indicates more ease of integration into clinical practice, or higher coherence, higher cognitive participation. We do see lower scores integrates a better outcome. So we do see that scores gradually decrease for each of, across the 3 clinicians. But like I said, it's a small number, so we need to take this with a grain of salt. It seems that the more that they use it, the easier it becomes for them to integrate it into their clinical practice. You see this a little bit more refined in the next slide, where we're showing graphs across the 3 clinicians, where you see the pattern that the general trend is that for each clinician is one line, that the scores tend to increase over time. But what this also helps us see is, and the nomad is also used sort of as a reflective or formative measure, that as you're implementing a system like the EPROM, there could be discussions around what is challenging for integration into clinical practice, what's going well, and be able to sort of iteratively improve workflow integration of the EPROM system. So as we continue this work in larger samples, we'll continue to collect the nomad on a larger number of clinicians within rehabilitation to be able to look at practice change within rehabilitation and the use of PROMs. So one of the other things we did, and Rania was extensively as our sort of lead champion and evaluator in the field, conducted interviews with patients and focus groups with clinicians. So I'll turn it over to Rania to present some of our qualitative results.
Thank you, Sarah. I'll now walk you through the qualitative findings from the patient interviews. We identified five key themes. The first one was the psychological challenges of living with a spinal cord injury. The second was how patients perceived patient-reported outcomes. Third, logistic and practical considerations. Fourth, facilitators of implementations. And finally, barriers and perceived value. Together, these themes give us a comprehensive understanding of how PROMs are experienced in real life beyond just numbers. So the first theme highlights the everyday reality of living with a spinal cord injury. Patients describe needing to carefully plan their day, even the basic activities like eating or using the bathroom. Others show that they think that their concerns may go overlooked, especially when care focused mainly on the physical symptoms. Many spoke about mental and emotional burden, like having to adapt and problem solving and doing coping all the day. This reinforces why PROMs are important. PROMs capture dimensions of health that are often invisible in routine care. About how patients perceive patient-reported outcomes. Patients generally have positive perception of PROMs. They think of it like an opportunity for reflection, helping them to think about aspects of their health that they normally might not consider. They help us also to do like clear conversations with their healthcare professionals. So beyond measurements, PROMs act as a tool of awareness and communication. However, patients also highlighted important logistic and practical considerations. Some of them asked for more flexibility, like adding a box to put their comments, not just only fixed responses to like multiple choice. Some of them asked about what difference this will make, emphasizing the need for visible impact. Many of the patients said that they feel more comfortable to fill the questionnaires at home, which give us idea about how important the environmental factors are. So implementation must be flexible, meaningful, and clearly linked to care. One of the main facilitators was the clear communication and feedback. Patients emphasized that when clinicians discuss the results and have conversation with them about what's really in the surveys, that means a difference for them. So we can say that PROMs create a value when they actively discussed in care. Patients also identified some barriers. Some of them are physical, like the patients who are severely injured need more assistance. Some of them are emotional, like when patients have depression or adjustment challenges, they make them less engaged. There are also some difficulties about recalling the information or difficulty to answer some questions. We cannot also overcome the ideas and the feedbacks from the patient about lack of internet and accessibility issues of having a device. So these findings highlight the need also of flexible, accessible, and more inclusive implementation approaches. For the perceived values, like we can say that despite all the barriers we mentioned, patients clearly valued the PROMs. They described it as a tool of learning and understanding of their conditions. They felt that it helped them more effectively communicate with their healthcare providers. But they also said that they want to see how this can be used. So again, we can say the prompts are valuable when they lead to meaningful feedback and more action. From clinician perspectives, we can say that clinicians valued the prompts in their workflow. It helped them to make more planning for the care and improve the communication with the patients. However, they mentioned some obstacles like the time constraints, workflow constraints, and integration issues. So clinicians support patient-reported outcomes, and success depend on how well they are integrated in their workflow. Based on our findings, four key success factors emerged. EMR integration, like when they are embedded into existing systems, they increase the use. Real-time feedback, so if the results are not available on time, they will be less used. Conciseness, short surveys make it easier for the patients to fill the surveys. And clinician training, which ensure they can interpret the scores. We can also talk about the pitfalls and things that may affect sustainability, like parallel systems. If you are printing and using paper at the same time, that increase the friction and lead to abandonment. The black hole, like collecting data without discussing it, make the patient doesn't trust that there's value of filling the questionnaires from the beginning. Timing delays, we mentioned this, that if it is not ready after the appointment, it's irrelevant. Resources constraints can stop the implementation entirely, like we mentioned in the Montreal site. So I'm handing this back to Sarah to walk you through the next step. Thank you.
Thank you, Rania. So I just wanted to end by just saying a few words of the broader perspective. And since 2016, we've been working on thinking about how do we make patient-reported outcome data collection a staple part of our healthcare system, at least in Canada. And we convened a group of decision makers, policy makers, individuals with lived experience with various chronic conditions, and clinicians and trainees to reflect on this. I would say that what we identified then is still extremely relevant today, and we've seen similar results across other countries that would like to integrate PROMs more at a national level for policy planning, but also at healthcare organizational and individual treatment planning levels. And there's still a lot to do around better understanding which outcomes are core and how do we get over this sort of multiple outcomes being used. And there are organizations like iChum and others that help to think through that. But regardless of which teams we've worked with, it always starts off by picking that core set. So our aim was, in spinal cord injury at least, was to help think through what is that core set and make sure that it's collected across all the clinical sites, at least the ones that we were working with. There's a lot around the science, although the science has advanced quite a bit in terms of cultural adaptation and thinking about the measurement properties of tools. And then everything that we've shared today and that Rania mentioned around facilitation of implementation, we know enough now to really think at our organizational level, how can we facilitate the use of patient-reported outcomes and what type of learning is needed at the clinician and at the individual patient and family level. So we're hoping to continue this work through our partnerships, but also mainly through the experiences that we have on the ground with the rehabilitation programs. And we're at a time now where there's a lot of digital health transformation that's happening. It doesn't solve all the challenges, but it certainly helps when that infrastructure is there around iteratively being able to facilitate the integration of PROMs in clinical practice. So this will be recorded and you can go back to this, but we just wanted to remind everyone around a few points of ultimately what we're trying to achieve is a system where we can collect and share PROM scores at the patient program, which is the meso, and at the population level, which is at the macro. And the last, I sort of outline the areas where it could be extremely valuable to have PROM scores at each of those three levels. The feasibility and standard of care, we know that from this study, it is feasible to implement PROMs. We do see a relatively high level of acceptability, but that the clinical value really depends on successfully administering the outcomes that are most important, that are likely to drive patient-centered care. So based on these results, we will continue to move forward and look and go back to our clinical teams and expand through some of our national initiatives to think through how could we enhance the administration of spinal cord injury EPROMs. Now, one of the comments that we've received through this project is, are these better suited to administer once somebody is discharged post-rehabilitation? And I think the reflection that we've had through our stakeholder engagement team is that there is a huge value to start administering these within inpatient rehabilitation before somebody goes home in order to help with that continuity and service planning over time. Like I said, we'll review the results with the healthcare organizations. There's also currently a national spinal cord injury initiative that's examining all of the assets we have across Canada for spinal cord injury care. So we will continue to work with that team to see where there's a need and where there's interest for really thinking about EPROMs, especially where there might be electronic health records that are rolling out that could more readily plug in the EPROM system to integrate it within clinical workflow. Rania talked a lot about the importance of sharing the scores, that there's no value in collecting a lot of EPROM data if it can't be shared back with family members and with patients and individuals with lived experience themselves. So one of the next steps will really be at examining how do we do that, and does it have to wait to go through the care team? Or should we have feedback mechanisms to individuals themselves, especially when they're in the community? It can almost be like an untethered sort of review of, check my health related quality of life that they can share with community support systems that they have in place, or health professionals as they receive care through the health system. And then we're always thinking about scaling up and the education part of this and the learning, especially as we start to talk more about learning health systems, is what are sort of the microbites of learning that we can integrate within our health system to help support clinicians around the understanding of the value of PROMs and how to best integrate them within clinical workflows, as well as for individuals and family members, how to access those PROMs, how to interpret the scores, and how to share them to support communication and shared decision making with their healthcare team. So I think we're going to stop there and see if there are any questions, and we welcome you to contact us if you have any suggestions as we move forward, or any other questions or feedback that you would like. Thank you.
Thank you, Sarah and Rania, for your great presentation. Like Sarah said, we will open up the webinar now for questions. If you are like me and would rather ask questions via email, I will put both of the speakers' email addresses in the Q&A. So I don't see anything right now. I do want to just reiterate how important this effort is, and really thank you for taking this on. I do wonder, do you have any plans to expand on the qualitative piece for the clinicians? Because I suspect perhaps the longer clinicians incorporate this into their usual practice, and they get to see the feedback process with the patient, that perhaps they'll see the value and the burden will be less, and it'll be easier to incorporate. Do you have any thoughts on that?
Yeah, I'll maybe start, Rania, and then you could add if there's anything else. But I think, it really comes down, Angela, to the sort of the juggling the different pressures. So there are two main things that came out of this. One was the integration of the workflow, and in Parkwood, we were able to get further in that implementation because they had the EMR. They already had that practice change of looking at information online and using it within the clinical encounter. So we added the EPROM. But there is a second layer, and the second layer was even though we did the Delphi to find the core set, not they didn't always agree with the ordering in which the items were selected for a given client or a given individual that they were working with. So we would troubleshoot questions like I don't agree. Like I answered an item and then it gave me this other item for the client, and we're not agreeing with that. Like the client is asking me why they're asking me, and I maybe Rania, you remember the details of sort of the order if you want to add to that, but it's also having trust in the measure or the that's being used. Now, there weren't a huge number of cases like that, but it just takes one or two for a clinician to sort of hesitate and maybe not use it or not feel as comfortable using it the next time. So we had to troubleshoot that. It required a lot of communication and support around that. Rania, I don't know if you have anything else to add about that sort of focus. Yeah.
I just want to add that everything is changing rapidly in the clinical settings. The EMRs are changing, they are advancing, updating, and we are also trying to go hand in hand with this. And I think that if we are looking at future steps that we can find more user-friendly EMRs and PROMs platform that will enhance the integration in the workflow and allow more clinicians to engage.
Yeah, great. I see that Gada Mosen has raised their hand. If you want to go ahead and speak, we can have Pete unmute you.
I just speak about our bottom on the floor. It's a phenomenon. It's about the children with spinal cord injury because they didn't, they don't um, receive stimulation or motor stimulation, so that they became or they their muscles became atrophied even with growth, and when they become adults they there will be more deterioration because there is no stimulation. So what is about dealing with this problem, because mainly they are affected with it. Thanks.
Thank you, Rada. I'm not an expert in kids with spinal cord injury, so I won't say too much about the clinical care. I mean, I do know some being a physical therapist. So I think that's really important. And of course, what you described as the impacts of spinal cord injury on children will have an impact on activity limitations and participation. So in terms of what we're presenting today, patient-reported outcomes also play a very important role for kids. Of course, parent proxy measures, but the PROMIS suite of measures on which the SCI QOL is based on does include pediatric measures. I'm not aware of SCI QOL being available for kids yet, unless Rania, you want to, my understanding is not available for kids. It's been developed only for adults. It definitely would be relevant to look at some of the PROMIS measures to see which subdomains, because some of them do come from PROMIS, like depression, for example, mobility, that could be used in kids. It would, similarly to what we'd shared with adults, plays an important role for care for children as well, to identify how is spinal cord injury really impacting their lives from their perspective, especially as they get older and can report, but also to support parents in supporting their children with spinal cord injury. So if you're interested, we can direct you to certain PROMIS measures that would be relevant, or other measures that would be relevant for pediatrics, and we can consult with our colleagues who would have more expertise and knowledge in that.
While others are coming up with questions, I have another one. I may have missed this. You may have said it. I apologize. But do you know how many countries the SCI QOL has been validated in? at this point, or is this still like a big work in progress?
I would say for the clinical, for the generating evidence of validity and translation, I only know of French. We could reach out to David Tulsky and find out from him if other countries have started using it. But the implementation is definitely a work in progress.
Mhm.
The integration into clinical practice of the SCI QOL is a work in progress. So we sort of did a comprehensive review just to see what's the state of the art right before coming on. And we see that there's still not a lot of reporting of clinical use of the SCI QOL.
Mhm.
You had asked the question, Angela. I don't know if we actually answered you about do we plan to continue the qualitative work with health professionals? The answer is yes. I think what
Yes.
we'll do is move on to a broader sample across Canada, at least for troubleshooting and thinking through the integration. Like Rania said, there's a lot of rapidly evolving changes in our health system, especially around digital. Everything's becoming digitized. So as that happens, we really want to get a better sense of what would be the success strategies around integrating EPROMs. But also, some of the challenges we talked about, the actual use of the scores themselves and decision making and better understand that so that we could sort of zoom out and do it more broadly across clinicians from different sites.
Yeah. I love that comment that participant made. They participate in all these clinical trials, but they never get any kind of results. And I hear that all the time too when I'm working with participants. So the way that this is presented is such a nice package to be able to go over with people. So that's so important. I do see a comment from Annette, my other co-chair of the Qual SIG. She says, "Great presentations. Maybe you mentioned, but what was the response rate?"
I'm going to turn over to Rania. I think getting our numbers up was the hardest part in these sites, and maybe I'll comment on that. But first, I'll let Rania answer directly. What was our response rate?
Yeah, so we didn't know actually the denominator because it was the recruitment was on the other sides, but we know that the adherence rate like 50% in the sites where they have multiple time points like Parkwood. So for 50% of the people who did the admission did the follow-up. I
Yeah.
hope I answered
A
the
lot.
question.
Yeah, so it's pretty low, and but it's two things. It's not the willingness of or the interest of individuals with lived experience to participate. It's also the clinical team and sort of the steps of recruitment that comes with research that sort of added a layer of complexity to the whole process. One of the things, and I think I alluded to this, is we're really wondering you, integrating anything into the health system is complex. And so, do we go straight to the individual lived experience and have them sort of the owner of their PROM, profile data, whatever we might call it, whatever they choose to call it, that they can share and take with them and sort of self-monitor over time. And I think if we can make this responding to the EPROMs easier, sort of like we have our watch and we can monitor our steps and we can sort of, or our wheelchair mobility or, sleep quality, whatever it might be. Can we do the same with proms that we just sort of do a self health check-in and be able to share those scores and then work with health professionals? It might reduce some of the layers and the complexity of integrating the scores into just everyday sort of care and reflection around our own health and what we report on when we see health professionals.
Question. Any other questions? Well, as I said, I included both Rania and Sarah's email address in the Q&A. So if you do think of questions or you have comments and want to reach out, please feel free to do so. I do want to just thank you guys again for your time and for presenting today. This is wonderful effort that you guys are moving forward. And thank you to ISCOS for providing this platform. And just a quick plug, if you're interested in quality of life outcomes, I invite you to join our special interest group. In the chat, I'll leave a little bit of information about what it is that we do and our goals, and then I'll leave my contact info if you have questions or if you would like to join.
Thank you,
So
Angela. Thanks everyone for attending.